All right, so let's just start with the video. As you guys know that I understand that you are here for our second cardiology session on, especially we finished the myocardial infarction, which was very, very important for you. I guess the first lesson was very helpful for you. And if any one of you haven't heard our first lesson, it's a very, very important class. So most of you will get one or two questions from that class. So very important, finish that obviously. We have the recordings in our group and also the live session in the group. So you can easily find it out if you just go to the search option and just write as like you can search it by writing recording. So any of the recording of our classes will come up. Today's session is mainly on lecture 2 from cardiology, which will be mainly from congestive cardiac failure, another important topic for you. We will also go through some other cardiomyopathies, hypertension, and if we get some time, then we will go through palpitation as well. Otherwise, palpitation will be more covered during our ECG class, which will be done usually in our courses, not in the free sessions. And after that, we will take a exam for you on cardiology, and also those of you who already joined in our 5 months course, you know that we have given you some of the books already. We are approving you to our software, so we will be able to see our Q banks. You will be able to go through our exam questions and also all the notes as well. So let's just start with the cardiology lecture 2 today. If you guys have any problem or if you don't understand anything, those who are in the Zoom, you can write it in the chat box. Those who are in the Facebook Live, you can also comment. I would advise most of you to come to the Zoom because normally we take classes on Zoom. Just because of these free sessions, we are taking it in the Facebook Live session, but it's always good to be in the Zoom because it's more interactive rather than the Facebook. Okay, so as always, we usually start with a video of our main topic. So tonight's main topic is congestive heart failure. We will start with a video of what actually congestive cardiac failure is. Let's start with it.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
So you understand that what congestive cardiac failure is that when your heart is unable to pump enough blood to your body, that's mainly what is congestive cardiac failure. Now, when heart is not giving enough fluid or enough blood to your body wants to retain some fluid because to maintain the balance. And the main part is usually done by your kidney. Your kidney will then try to reserve some sodium and water. Now that sodium and water retention will cause your body to swell up. So everywhere in your body there will be fluid accumulation. So in your leg you will get leg edema. In your abdomen you will get fluid accumulation, which we call ascites. In your lungs you will get fluid, which we call pulmonary edema. Also sometimes you will get hepatic congestion, that's why you can get tender hepatomegaly. Then also your superior vena cava or the jugular vein will distended, that's called like raised JVP. So all these features are mainly due to the fluid accumulation. And the main cause is that like your heart is unable to pump enough blood to your body. We'll go through all these things tonight, and I guess you will understand what is congestive cardiac failure and how we can manage this situation. Let's just start with a question. A 60-year-old man presents to your primary care physician for several months of dyspnea on exertion, exercise intolerance, and lower extremity swelling. So you have got shortness of breath. So if your lungs congested with fluid, you will get dyspnea or shortness of breath. You're you're having lower extremity swelling, which is the pedal edema. He has a past history of sarcoidosis. On physical examination, jugular venous distension and pitting edema in the lower extremities are positive. And you did a echocardiogram which shows ejection fraction of 35%. In a normal person, ejection fraction should be in between 45 to 55. So obviously this ejection fraction is low. Ejection fraction means that, remember, your heart has a systole and diastole. Systole means when your heart, when mainly always think about the left ventricle, because left ventricle gives them all the pumping. So when the left ventricle squeezes, that's systole. When the left ventricle distend, that's your, or when the left ventricle relax, that's your diastole. During systole, the blood from your left ventricle should squeeze out of the heart to the aorta and to the whole body, right? Now that is squeezing, that's how much blood is going out. That's mainly calculated by your ejection fraction. So ejection fraction gives you an idea about the systolic function of the heart. Clear? So sometimes echocardiogram can confirm your diagnosis of heart failure if the ejection fraction is less than normal value. Normal ejection fraction should be in between 45 to 55%. So you have got two cases here. A 62-year-old man with hypertension and dyslipidemia presents with dyspnea and lower extremity edema for 2 months. There is JVP elevated, S3 gallop, which is another feature of heart failure. Apical impulse is displaced to the left. Chest X-ray shows enlarged cardiac silhouette, and echocardiogram shows a dilated left ventricle with an ejection fraction of 35%. So ejection fraction low means that systolic function is low, which means it's a systolic heart failure. There are mainly two types of heart failure. One is systolic, another is diastolic. The same patient, a 57-year-old, coming with a history of multiple myeloma, having dyspnea and lower extremity edema for 2 months. JVP elevated, S4 is audible. In a normal patient, S1 and S2 is the normal heart sound. When you hear S3 or S4, that's normal. That's not normal, that's an abnormal heart sound. Apical impulse is non-displaced. Chest X-ray shows normal cardiac silhouette. Echo shows a thickened left ventricle with an ejection fraction of 65%. Now, ejection fraction 65% is more than normal, right? So this sort of things is called diastolic heart failure. Diastolic heart failure in which your heart cannot relax. Your heart needs to relax to fill in the blood, right? So when your heart is unable to relax, that's your diastolic heart failure. Now, again, go to the video. It will help you to understand this diastole and systole.
The
So you see that when the heart is distended, it means that it's getting relaxed to get the blood from the lower extremities. So this is your mainly this is right ventricle. This is right atrium, right ventricle, left atrium, left ventricle. Blood from the superior vena cava will come to the right atrium. Also, inferior vena cava will come to the right atrium. From the right atrium, blood will go into the right ventricle. Then, as I said in the previous session, then it goes to the pulmonary artery to your lungs, and from the lungs, pulmonary vein carries the blood into your left atrium, then to the left ventricle, and then it goes to the aorta and to the whole body. That's how the heart circulation works. Now, systole and diastole, what happens?
Lower left
See this
chamber
one.
of the heart, called the left ventricle, is the
So you can see heart is squeezing and relaxing. The squeezing part is the systole. When the heart is squeezing the blood out of its region to the blood, to the whole body. And when it's distending, it means it's relaxing to receive the blood from the lower extremities. Systolic heart failure means when this contraction of the heart or squeezing of the heart is impaired, then heart will be unable to pump enough blood, and then what will happen? Your body will not get enough blood. Diastolic dysfunction, on the other hand, the pumping is good, but it cannot relax enough to receive blood from the extremities. So the relaxation or distension of the heart is impaired. That's called diastolic dysfunction. So that's the mainly two most important basic you should understand about this two subtype of heart failure, because the treatment is different, presentation is also little different. So we need to understand the pathophysiology of both of these two subtype. Now, any patient with a heart failure, usually they will come to you with shortness of breath, especially the shortness of breath will be on exertion or doing a lot of exercise. So shortness of breath, again, the shortness of breath will be more worse when they lie down, because when they lie down, the blood from the lower extremities goes to the lung, and lung gets more congested. So when they lie down at night, they usually have more shortness of breath, which we call orthopnea. Okay, so those patients usually gets more relief with like more than one pillow to raise up their head. So dyspnea and orthopnea, that's one of the feature. Patient can have some dry, irritating cough at night. Patient usually comes to you with feeling lethargic and fatigue because their sleeping will be impaired. They can get wet because there is a fluid accumulation. There will be swelling of the legs because of fluid accumulation, abdominal discomfort because of fluid accumulation in the abdomen, and also hepatic congestion. Because of low cardiac output, they can also feel dizzy, because if your heart is not pumping enough blood, your brain is not getting enough blood and oxygen, so you can feel a little dizzy and weak and fatigue. And sometimes even you can fall and had a loss of consciousness, which you call syncope. So main symptoms of heart failure is dyspnea on exertion, orthopnea, swelling of the legs, abdominal discomfort, and sometimes those patients usually gets like very disturbed sleep. So they usually wake up in the middle of the night gasping for air or catching up for breath. That's called paroxysmal nocturnal dyspnea, PND. That's also common in heart failure patient. Now, there are, depending on the right and left side, you can have left heart failure, you can have right heart failure. Left heart failure means that the left ventricle is not working properly. Okay, so mainly for left heart failure, your main feature will be patient will have shortness of breath. Patient will have some of the clinical feature which will help you to understand. One of them is called bilateral basal crepitation, H3 gallop rhythm, and they will also have some like mainly shortness of breath and laterally displaced apex beat. Now, first of all, to understand left and right heart failure, you have to understand the pathophysiology, as I have been talking about for this time. So as I'm saying that this is your heart, this is the right side, this is the left side, right? And you have got your pulmonary arteries, which goes into your lungs, right? And from the lungs, pulmonary vein comes up, and it gives oxygenated blood to your left atrium and left ventricle. And from here, the aorta comes up. So this is your pulmonary because it's blue because it's contained the deoxygenated blood. And this side is also blue. Okay. Now, what will happen in left heart failure? Your left ventricle is not pumping enough blood to the body. So there will be fluid accumulation in the left ventricle, and then left ventricle will be overfilled, and then left atrium will be overfilled. Due to that, then gradually the pulmonary vein will be overfilled, and then the lungs also will get congested. So that's why you will get pulmonary edema or congestion in the lungs. Okay, so left heart failure causes the pulmonary edema. When you have fluid in the lungs, you will get bilateral basal crepitation. And also you will get abnormal heart sound, which we call gallop rhythm. Now remember, for left heart failure, the main feature is this bilateral basal crepitation. For right heart failure, what will happen? Say that your lungs is congested. Then what will happen? Before lungs, there is pulmonary artery. Then the pulmonary artery will get congested because of fluid accumulation. And also your heart is not pumping enough blood. Now pulmonary congestion, then the right ventricle get congested, right atrium get congested, and then also the superior vena cava, inferior vena cava, from which the blood was coming to your heart, that's also getting congested. At that time, you will develop right heart failure. So left heart failure eventually gets complicated with right heart failure. And when you get right heart failure, you will get raised JVP in your neck. You will get lower extremity edema, so bipedal edema. You will get congested liver, which will, like, because of congestion in the liver, you will get hepatomegaly, which will be tender hepatomegaly. So for right heart failure, the main features are elevated JVP, ankle edema, and hepatomegaly. Clear? So this is how you can find out that if this patient is having left heart failure or right heart failure, just by looking at the symptoms. Any questions so far? So normally in heart failure, the main physical features that you look for is you look for bibasilar capitation, you look for raised JVP, you look for ascites and tender hepatomegaly, you look for bipedal edema. Clear? So if you see this video, you will get more confidence with this.
Heart failure occurs when the heart is unable to provide sufficient blood to meet the body's needs. Heart failure is not a disease on its own, but rather a consequence of other underlying conditions. The impairment of the heart function can be due to an inability to pump effectively during systole, called systolic heart failure, or inability to fill properly during diastole, called diastolic heart failure. Heart failure can be right-sided or left-sided, depending on the side that is affected. About 2/3 of all left-sided heart failures are caused by systolic dysfunction. In systolic heart failure, ventricular contraction is compromised. This may be caused by any condition that weakens the heart muscle or creates more difficulty for the ventricle to pump. The most common include coronary artery disease and its consequences. Plaque buildup narrows the coronary artery, reducing blood supply to the heart muscle. Complete blockage can cause heart attacks, which often leave behind non-functional scar tissue. Dilated cardiomyopathy. The ventricular wall is dilated, becomes thin and weak. Hypertension. Higher systemic pressure makes it harder for the ventricle to eject blood. This is because the pressure in the left ventricle must exceed the systemic pressure for the aortic valve to open. Valvular heart disease. Damage to the valves, such as stenosis, also makes it more difficult for the ventricle to pump. The effectiveness of ventricular contraction is measured by the ejection fraction. Typically, the left ventricle is filled with about 100 milliliters of blood, but only 60 milliliters is ejected during contraction. This corresponds to an ejection fraction of 60%. The normal range of the ejection fraction is between 50 and 70%. When ventricular contraction is impaired,
It's normally we keep it as a 45 to 65.
the volume of ejected blood is reduced, and so is the value of the ejection fraction. In systolic heart failure, it drops below 40%. In diastolic heart failure, the ventricle is filled with less blood. This may be because it is smaller than usual, or it has lost the ability to relax. The ejection fraction may be normal, but the blood output is reduced. The ejection fraction is therefore commonly used to differentiate between systolic and diastolic dysfunction. Examples of conditions that can lead to diastolic heart failure include hypertrophic cardiomyopathy. The heart muscle grows thicker than usual, leaving less room for blood filling. Restrictive cardiomyopathy. The heart muscle becomes rigid, unable to stretch. Hypertension can also cause diastolic dysfunction indirectly via compensation mechanisms. As higher systemic pressures make it more difficult for the ventricle to pump, the heart compensates by growing thicker muscle to try harder. Larger muscle means reduced space for blood filling. Regardless of being systolic or diastolic in nature, left-sided heart failures share a common outcome: less blood pumped out from the heart. As a result, blood flows back to the lungs where it came from, causing congestion and increased pulmonary pressure. As this happens, fluid leaks from the blood vessels into the lung tissue, resulting in pulmonary edema, a hallmark of left-sided heart failure. Accumulation of fluid in the alveoli impedes the gas exchange process, resulting in respiratory symptoms such as shortness of breath, which worsens when lying down, and chest crackles. Right-sided heart failure is most commonly caused by left-sided heart failure. This is because the increased pulmonary pressure caused by left-sided heart failure makes it harder for the right ventricle to pump into the pulmonary artery. This results in systolic dysfunction. In compensation, the right ventricle grows thicker to pump harder, which reduces the space available for filling, eventually leading to diastolic dysfunction. Other common causes of right-sided heart failure include chronic lung diseases, which also raise pulmonary blood pressure. As the right ventricle pumps out less blood, the blood again backs up to where it came from, and in this case, the systemic circulation. This results in abnormal fluid accumulation in various organs, most notable in the feet when standing, sacral area when lying down, abdominal cavity, and liver. The fluid status can be assessed by examining the distension level of the jugular vein. Heart failure is usually managed by treating the underlying condition, together with a combination of drugs. ACE inhibitors and beta blockers are used to reduce blood pressure in patients with systolic dysfunction. Diuretics are used to reduce water retention.
Okay, so this should give you a clear idea on what is diastolic heart failure and what is systolic heart failure. Now, we already know that to differentiate between these two, we need to find out the ejection fraction. If the ejection fraction is less than 40, that's systolic heart failure. If more than 40 or more than 50, diastolic heart failure. Now, the causes of heart failure. So systolic heart failure is impaired ventricular contraction. Diastolic heart failure is the impaired ventricular relaxation. If you want to confirm your diagnosis of heart failure, then you have to do an echocardiogram to confirm it. The main cause of systolic heart failure is ischemic heart disease or any history of previous myocardial infarction. That's the main cause of systolic heart failure. So any patient having systolic heart failure, you should always think about underlying myocardial infarction. And also hypertension is another common cause. For diastolic heart failure, again, you already know. So mainly we will think about it could be hypertrophic cardiomyopathy, sometimes pericardial disease, atrial fibrillation, hypertension, aortic stenosis. They mainly can cause the diastolic heart failure. But the main risk factor is obesity, hypertension, and diabetes. To investigate any patient presenting to you with heart failure symptoms and signs, the initial investigation always should start with a ECG. That's one of the very commonly asked question in your exam. Even though it's clearly evident that this patient is having heart failure, if they ask what is the next investigation you are going to do, any patient with a first presentation or worsening heart failure presentation should get an ECG first before going for echocardiogram. Because echocardiogram, this is a special kind of investigation. You cannot do it on the bedside, okay, if you want to do a formal echo. So obviously you should do an ECG first in any of these patients. Don't choose is incorrectly as echocardiogram, BNP, anything like that, because those we do those investigations obviously, but not as an initial investigation. So initial investigation for any heart failure patient or any heart condition is your ECG first. After you do the ECG, the next one you can do as to confirm it is echocardiogram. So echo will help you to find out the ejection fraction and also if there is any underlying valvular disorder, any regional motion abnormalities. So everything will be given by the echocardiogram. Now, if you want to find out the severity of heart failure or prognosis of heart failure, then you do another test called beta or B-type natriuretic peptide, which is BNP. BNP is not for diagnosis of heart failure. Please remember that. Many candidates I have seen that they are choosing BNP to diagnose heart failure. It's not for diagnosis, it's to find out the severity of BNP, severity of heart failure or prognosis of heart failure. So you diagnose with the echocardiogram that it is a systolic or diastolic heart failure, and based on that, now you can treat the patient. For systolic heart failure, our stepwise treatment will start with the ACE inhibitor first. So you will start with the ACE inhibitor. That doesn't help, then you give diuretics. Start with the furosemide. That doesn't help, then you can add spironolactone. If still there is congestion, then you can add a selective beta blocker. And last option for heart failure is your digoxin. Remember, digoxin is a highly toxic drug, so it has a very narrow therapeutic index. So chance of poisoning or toxicity by digoxin is very high. So we don't usually use it initially for heart failure. Previously we used to, but nowadays we have a lot of good medications rather than using a digoxin. It is the last resort. So first of all, always start with the ACE inhibitor. Then also, because in systolic heart failure, what will happen? Your body will try to reserve water and salt, right? So you can give diuretics to remove that excess water. So you can use furosemide, spironolactone, and also ACE inhibitor will also like will block this sodium and water retention. So you can give the ACE inhibitor also. So that's why we use ACE inhibitor, furosemide, spironolactone for this patient. Now remember, we use beta blocker in heart failure, but only if the patient is a stable heart failure or chronic heart failure or euvolumic heart failure. Any patient who is congested at the moment and or we call it decompensated heart failure, that means all the body swell up, patient having severe shortness of breath due to pulmonary edema, you should not use beta blocker to those patients. Why? Because when you use beta blocker, what you are doing, beta blocker usually reduce the contraction of your heart, right? So if and systolic heart failure already the pumping action is reduced. So if on the top of that, if you use beta blocker, it will get a lot of worse. So during when the heart is stable or your heart failure is stable, then you can use beta blocker because it helps with cardiac remodeling. But if patient or now at the moment having acute pulmonary edema, congested, or having shortness of breath, you don't use beta blocker at that time. This is also one of the very commonly asked question in the exam. So for systolic heart failure, what's your first line medication? ACE inhibitor or ARB. Also, then gradually you can use furosemide, spironolactone, beta blocker, and digoxin. So this is the flow chart. Okay. See that beta blocker has an important part of heart failure therapy because along with the ACE inhibitor, beta blocker have demonstrated to decrease the mortality, reduce hospitalization, improve function, improve ejection fraction. So this has a mortality benefit. That's why beta blocker is a very important part of your heart failure management. Start patient on beta blocker when the patient becomes stable with diuretic and ACE inhibitor. What we use, usually we can use carvedilol, metoprolol, bisoprolol because these are selective. Okay, selective beta blocker, that means cardioselective beta blockers are better. After systolic heart failure, then you go to the diastolic heart failure. Now, diastolic heart failure, so if there is any underlying cause like hypertension, ischemia, diabetes, you have to have a good control of those underlying causes. The basic treatment in here will be mainly giving some ionotropic agents. Mainly, you will use something to reduce the contraction or its squeezing of the heart, because diastolic heart failure, your heart is not getting enough time to fill in or relax. So if you can reduce the contraction of the heart, so your heart will get more time to get relaxed, right? So what you can use for this patient, you can use beta blocker or rate limiting calcium channel blocker. Only these two drugs causes like reduced contraction of your heart. So that's why you use calcium channel blocker, mainly verapamil or diltiazem. This is your rate limiting one, and also beta blocker. Always try to avoid diuretics because diuretics will remove water from your body, and if you, because your heart is not getting enough blood, if on the top of that you are removing blood or fluid from your body, it will get worse. Okay, so that's why you don't use anything which causes excess water removal from your body. Like you don't give diuretics, don't give digoxin, don't give any vasodilator like nitrates, because if you give vasodilator, the peripheral blood vessels will be dilated and there will be peripheral pooling of blood in your extremities. So your heart will not get enough blood. So it can make things worse. So don't give vasodilator or nitrate in these patients. So these are the three drugs which improve survival in chronic heart failure patient or congestive heart failure patient: ACE inhibitor, beta blocker, and spironolactone. Sometimes in the question they ask which one of the following has mortality benefit for heart failure patient. So that's why we need to remember these things. So you don't use diuretic in patient with diastolic failure. Why? Because what's the diastolic failure? It means your heart is not getting enough relaxation, which means your heart is not getting enough blood, right? If you use diuretics, what diuretics will do? Diuretics will remove water from or remove fluid from your body, right? If your body is dehydrated, your heart will not get enough blood, right? If your heart doesn't get enough blood, on the top of that, already it cannot relax and get enough blood, so it will make things worse. You don't want to make diastolic failure more worse by using diuretics. The basic physiology of diastolic heart failure is that your heart is not getting enough blood. So you don't want to use anything which will reduce your blood volume more. So you use diuretics. What is happening? You are from the body, you are losing fluids, You're losing plasma and everything, right? So you don't want to do that. Yes, it now there's the tricky part. You not all edema and ascites you will just remove it with diuretics. That's why it's important to know that is this patient having ejection like diastolic or systolic heart failure. That's the only reason why we need to know about that. Otherwise we can just give diuretics to everyone. It's not like that. You don't want to, like in diastolic heart failure, you can reduce the edema and ascites by using beta blocker and calcium channel blocker. Because why? If you can give your heart enough time to be relaxed by using a beta blocker or calcium channel blocker, what will happen? Your heart will get enough blood, and on the top of that your heart has good systole. So you, if your heart is filled with blood now after using those medication, with a good systole, your body will start getting enough blood. So your body will not reserve or accumulate fluid like before. So there will be no edema and ascites. So important, these are important things, because if you give diuretics to a patient who is having diastolic failure, you're making things worse. You're making the heart failure worse. Okay, it's just not like that. Every patient who is congested, just give diuretics. We can do that, but eventually things can get a lot worse with even our notice. And that's the only reason why we need the systolic and diastolic heart failure classification. Otherwise, it's not very important, right? So always before giving medications to this patient, we need to find out that is a systolic or diastolic heart failure. Now, remember one thing, sometimes as you have seen that some patient can present to you with a left heart failure, mainly with pulmonary edema. Now, when you use furosemide and when you don't use furosemide, that's also important. The good thing to understand about that is that heart failure patient, always they will have some edema in their legs, and even it can come up to the knees, getting like bipedal edema, but only as a first line medication, you have to use furosemide or spironolactone if a patient having congestion in their lungs. So if any patient presents to you initially with like having severe congestion, severe shortness of breath, and that's called acute pulmonary edema due to left heart failure. At that time, you have to use both AC inhibitor and furosemide initially. Okay, but if the patient is only having swelling in their legs, there is no pulmonary congestion, you don't need to even start with the furosemide first. You can only start with the ACE inhibitor and then see how it goes. So the indication of using combination medication at the first go, like using ACE and furosemide at the first time or initially without starting a single medication, is only when a patient have pulmonary edema or having severe lung congestion. Clear? Sometimes exam question give you some scenario like a patient coming to you who was used to use some of the medications for heart failure, went to a trip, and then she could not take some of the medications and now presents to your GP clinic with swelling of their legs up to their knees. There is no bibasilar crepitation. Now, if there is no bibasilar crepitation, there is no pulmonary edema. For those patients, you can just start all the medications patient used to take before. Like if the patient was taking ACE inhibitor, diuretics, furosemide, everything is was taking, you will just recommence all the medication and gradually it will improve. But if that same patient comes to you with pulmonary edema with bibasilar capitation, shortness of breath, you have to initially start with the furosemide and then other medication. So furosemide will be a vital medication in that part. So these are the commonly used diuretics for heart failures. Why these medications are important? Because these are the medication can cause some complications. Like your thiazide diuretics, it can cause some of the electrolyte abnormality, which is very important for your exam. So thiazide causes hyponatremia, it causes hypokalemia, but it causes hypercalcemia. As it causes hypercalcemia, it also causes hyperuricemia and it can precipitate gout. So for gout patient, you don't use thiazide diuretics. So just remember these three things: hyponatremia, hypokalemia, hypercalcemia, and hyperuricemia. Also, thiazide diuretics can increase your glucose intolerance. So diabetic patients should not use these thiazide diuretics. Clear? Indapamide also one kind of thiazide kind of drugs, but hypokalemia and lipid abnormalities are less common. But it causes hyponatremia, hypokalemia, all the similar complication like thiazides. Loop diuretics, mainly your furosemide or bumetanide, this causes again hyponatremia, hypokalemia, but it causes hypocalcemia. Also, this furosemide has a very much notorious effects of ototoxicity. Okay, so you just need to remember these side effects of this medication because sometimes drug interactions come in your exam. And lastly, you have got a spironolactone, which actually resolves potassium in your blood and it causes hyperkalemia. And spironolactone also notorious to cause gynecomastia. No, beta blocker, using beta blocker, Dr. Manal, is not dependent on blood pressure. It depends on your fluid status, not the blood pressure. Blood pressure, beta blocker has very low effect on blood pressure. So it doesn't need to be stable or anything. It mainly patient needs to be having a compensated heart failure when you start a beta blocker. So that's your common diuretics we use in heart failure. Remember one of the other medication we used, digoxin or digitalis. Now digoxin is very important because if a patient is on digoxin, those patients always we need to find out that if this patient is having any digoxin toxicity or not. Now your digoxin, it works in a way that it inhibits your sodium potassium ATPase pump. When it inhibits the sodium potassium pump, it increases the intracellular sodium and decrease the intracellular calcium. Mainly, it decreases the exchange of intracellular calcium. If the calcium is not exchanging, what will happen? There will be more calcium in the cell. Normally, what should happen? Calcium should go out of the cell, but when it inhibits the sodium potassium pump, the calcium is inside your cell. When calcium is inside your cell, it causes more contraction. So digoxin can improve the cardiac contractility, and that's why you use it in systolic heart failure. Okay, so cardiac contraction gets better in here. Now, the most important thing that you need to understand from digoxin toxicity. So let's assume this is one of your cell, and this is the receptor. Okay. Now, your potassium. Let's assume this is a myocardial cell. This is the potassium, and this is the digoxin. Your digoxin and potassium both use the same receptor to get into the cell. So, if any time there is increased potassium in your blood, more potassium will be attached to the receptor. Okay. So, the digoxin cannot go into the cell. If digoxin cannot go into the cell, it will cause more digoxin into your plasma or blood. So you will get hyper, like means high digoxin level in your blood. So if any patient having hyperkalemia, okay, if any patient having hyperkalemia, it means that potassium is binding to this receptor more. Digoxin cannot bind into the receptor. Digoxin cannot act on your cell. So hyperkalemia reduce the digoxin activity. But if you have hypokalemia, that means your potassium is low, more digoxin is going into your cell and it can cause digoxin toxicity. So the main thing is to remember that if any patient having hypokalemia, there is a possibility that that patient can get digoxin toxicity. What are the other features of, or what are the other risk factor when you can digoxin toxicity? Digoxin is removed or cleared by the kidney. So if you have kidney failure, there is a possibility of digoxin toxicity. If you have hypothyroidism, there is a chance. If you have hypercalcemia or hypomagnesemia, it can cause digoxin toxicity. Not very important to remember. The important thing to remember is that sometimes some of the medication interaction can happen with digoxin. Like if you use verapamil or diltiazem, what can happen? The digoxin toxicity can get increased because verapamil and diltiazem decrease the renal clearance of digoxin. If you use spironolactone or thiazide diuretics or furosemide, also digoxin toxicity can get increased. How furosemide and thiazides causes digoxin toxicity? Because furosemide and thiazide both causes hypokalemia. If you have hypokalemia, the digoxin effect will be increased, right? So that's how it causes. So just to remember these things, this is not very important. The important to remember that what are the toxic effect of digoxin toxicity. The most common feature of digoxin toxicity is nausea and vomiting. Okay, so patient usually will come to you with anorexia, nausea, and severe vomiting. They can also have blurry vision and yellow halos around the objects. Patient with digoxin toxicity can cause any arrhythmia, like any paroxysmal atrial tachycardia, PVC or premature ventricular complex, bradycardia, any arrhythmia can be caused by digoxin toxicity. So how you treat those patients? First of all, you need to stop digoxin, and then also sometimes we measure digoxin level in the blood, but digoxin level cannot give you the confirmation that if this patient having toxicity or not. Sometimes a patient can have normal digoxin level in the blood, but still they can develop digoxin toxicity. So it depends on the feature of the patient. So if this patient having nausea, vomiting, having arrhythmia, having yellow halos around the objects, having blurry vision, you should think about digoxin toxicity. Stop the drug, and sometimes we also use a medication called digibind. Digibind is a kind of antidote for your digoxin toxicity. Clear? Any question, guys? We don't use it as a first line. Whoever it is, Galaxy A30, who you ask this question, beta blocker is not usually a first line medication for high blood pressure. Your first line medication for high blood pressure is either ACE inhibitor, calcium channel blocker, or diuretics. We will discuss the hypertension. We use beta blocker sometimes, but it's not our first line medication for hypertension. Beta blocker is mainly for controlling your rate, not for blood pressure. We can use it all. It has a little effect on blood pressure, but not that much like your diuretics or ACE inhibitor. Now, medical devices for systolic dysfunction. Some of the patient can develop like severe systolic dysfunction, especially those patients who has dilated cardiomyopathy. For those patients, we can use some cardiac defibrillator. Okay, so sometimes they ask you if a patient has a dilated cardiomyopathy and their ejection fraction is less than 35%, the best treatment for them is to give a automatic implantable cardioverter or defibrillator, AICD. So that's mainly for dilated cardiomyopathy. We can use the AICD, not for everyone. So pulmonary edema, we have been discussing about the heart failure causing pulmonary edema. See, if you look at the chest x-ray of any pulmonary edema patient, you will find out the lungs are pretty much congested. You can see this is how it looks like. Sometimes they call it as a bat wings appearance. You can see heart is also enlarged, right? And this is called bat wing appearance, congested lungs. See, if any patient having a heart failure features with this congested feature in the lungs, that's your pulmonary edema. That's bat wing appearance is very common in pulmonary edema patient. So if a patient having pulmonary edema, mainly those patients will come to you with severe shortness of breath, tachypnea. Patient can get bibasilar crepitation, and also you can get like patient, if it's very severe, patient can get cyanosis. Even sometimes they can produce a frothy, pink frothy sputum at the night time. So main treatment for them will be initially make them in a propped up position, because if the patient lying down as a flat, the heart failure will get more worse. So propped up position, give oxygen if saturation is low, and start with the diuretic first. So that's mainly all of your heart failure things. I guess the heart failure is finished. You don't need to worry about heart failure if you listen to this lecture. Everything should be covered with this lecture. Now, valvular heart disease. Valvular heart disease, you don't need to know everything about the valvular heart disease. The main thing that we need to know is the murmur. Sometimes in the exam, they ask that what is the murmur? Like they give a murmur characteristics and they ask you what is the diagnosis. Mainly the left-sided murmur is important. For the left-sided murmur you have mainly in your left heart, you have aorta and you have mitral valve. So it could be either mitral stenosis, mitral regurgitation, it can be aortic stenosis, aortic regurgitation. These four are mainly your important exam question. But the right-sided like pulmonary regurgitation, pulmonary stenosis, tricuspid regurgitation stenosis is not usually important or not asked in any question. Now if you go through this med bullet, you will find out all the murmur characteristics. It's pretty well written here. See that in here, if you go into the med bullets, so you have mitral valve stenosis, everything is pretty much well written. So you can give it a read from here. And also some of the features of valvular conditions and the murmur characteristics is given here. So now it's very hard to remember these murmur characteristics. For the benefit, I usually memorize one particular thing which helped me to remember these murmur characteristics. Always remember one and you can find out others just from one. So if it's a mitral stenosis, it's usually very common. So I will remember the mitral stenosis. For mitral stenosis, what is the characteristic of murmur? Mitral stenosis comes to you as a mid-diastolic murmur, and it's a kind of rough, rumbling kind of murmur. Okay, so we have got a murmur which is mid-diastolic murmur. That's your mitral stenosis. Let me show you how we can remember these things. Now, we have got a murmur which is mitral stenosis. Oh, sorry. This is your mitral valve, let's assume, and this is your aortic valve, right? Always remember, if your mitral stenosis is a diastolic murmur, just the opposite of mitral stenosis will be also diastolic murmur. Now, what is the opposite of mitral stenosis? Mitral is the opposite of aorta, so aortic. What is the opposite of stenosis? Regurgitation. So aortic regurgitation also will be a diastolic murmur. Clear? So you've got mitral stenosis, which is a mid-diastolic murmur, right? And you have got aortic regurgitation, which is a early diastolic murmur. Okay, see that if it becomes very easy, because in the exam there will be a lot of option: diastolic, systolic, mid diastolic, early diastolic. So if you can just, you can exclude most of the options just by remembering that. Now come to the other one. If mitral stenosis is mid diastolic murmur, what should be the aortic stenosis? Your aortic stenosis, so mitral stenosis, the other one is aortic stenosis. Aortic stenosis will be systolic murmur. Or you can remember in other way. If you want to remember other way, I think that's more easier rather than this one. Let's see that if mitral stenosis is mid diastolic, what should be the mitral regurgitation? So always remember, if stenosis is diastolic, regurgitation will be systolic. That means always it's opposites. It's not same. So your mitral stenosis is diastolic murmur. So the regurgitation will be systolic murmur. If aortic regurgitation is a diastolic murmur, then aortic stenosis will be a systolic murmur. See that how easily you can find it out just by remembering mitral stenosis. Now, mitral regurgitation is a pan-systolic murmur. That means throughout the systole, you will hear the murmur. And aortic stenosis is the ejection systolic murmur. That means when there will be ejection or when there will be blood coming out of the valve, at that time you will be able to hear the murmur. So ejection systolic murmur. Among these four murmur, two of these murmur radiates: mitral regurgitation and aortic stenosis. Your mitral regurgitation radiates to the axilla. Your aortic stenosis radiates to the neck or carotid. Okay? But MS and AR doesn't radiate. Now the site where you will hear it best. That's also important to remember. Let's assume this is your sternum. Just assume. So this is the second intercostal space. Okay. And let's say that this is the fourth intercostal space in here. Okay. And also fifth intercostal space. Now, this is the right side. This is the left side. This is fifth intercostal. This is fourth. This is second. Starting with the mitral valve murmur will be best heard in the left fifth intercostal space. So in here. So left fifth intercostal space, all the murmur like mitral stenosis murmur and mitral regurgitation murmur will be best heard in the left fifth intercostal space. Okay, so that goes your mitral valve. Now for aortic valve, this is a pretty interesting. Remember, your aorta arises from like this and it goes like this, right? Although aorta is your left-sided valve, the aortic stenosis murmur will be best heard in the right side, right second intercostal space. Because remember, it's the ejection systolic murmur. So when it ejects from here, okay, you will hear the murmur more better in this right side. So this is the only murmur which will make you a little confusing. Similarly, the pulmonary stenosis murmur from pulmonary artery arises from your right side but goes like this. Okay, so it also your pulmonary stenosis murmur will be best heard in the left second intercostal space. So that's a little confusing. Although aortic valve is your left sided, but the murmur of aortic stenosis will be best heard in the right second intercostal space. Just the opposite, pulmonary stenosis best heard in the left second intercostal space. Clear? Just don't confuse with the site because sometimes they make you confused with the location. Whereas your aortic regurgitation murmur will be best heard at the left fourth intercostal space in here along the sternal border. Cool? So we have got aortic stenosis murmur best heard in the right second intercostal space, aortic regurgitation murmur best heard in the left fourth intercostal space. We have got mitral stenosis, mitral regurgitation best heard in the left fifth intercostal space. That's mainly what you need to remember. Now, aortic murmur changes with usually if you change position from lying to sitting forward. So usually aortic regurgitation murmur gets more better when you ask the patient to take a deep breath in and stop. Okay. So during inspiration, so take a deep breath in and stop and leaning forward. That's the time aortic regurgitation murmur is best heard. And mitral regurgitation or mitral stenosis usually best heard when you ask the patient to turn to their left side and take a deep breath in and stop. Okay, so that's how we usually, this is called murmur changing with position and respiration. Clear? So aortic regurgitation and mitral valve murmurs, they usually change with respiration, they change with position. For aortic, the position change you do is to ask the patient to sit and lean forward. For mitral valve, they will lie down, but they will lie to their left side. So turn to the left, and then you ask the patient to take a deep breath in and stop. And then you can hear it better. Clear, guys? So that's mainly you need to remember. So you see that aortic stenosis murmur is a kind of ejection systolic murmur in the right second intercostal space. Mitral regurgitation murmur, hollow systolic murmur radiating to axilla, best heard in mainly at the left fifth intercostal space. Aortic regurgitation, early diastolic murmur at the left sternal border, which is left fourth sternal border. Mitral stenosis, this is the key of our whole things. So it's also mid diastolic murmur, best heard usually on left fifth intercostal space and with expiration. Remember, mitral prolapse, always there will be a mid systolic click. If you can just remember these things that I have discussed, your murmur should be fine. Any questions so far, guys? Have you understood the murmur thing? The main indication of digoxin, Dr. Manal, is only when a patient has heart failure due to atrial fibrillation. Even after using all other medication, like you use beta blocker, and then still due to AF, patient having heart failure, then last resort will be digoxin. Are you guys getting the thing, what I'm trying to say? Any question? Thank you, Dr. Rishko. Uh, yeah, that sounds good actually. If you guys are understanding what I'm trying to say, that's really appreciating. Okay, now we'll try to finish this cardiomyopathy and then we'll take a little break. Okay, now we have three types of cardiomyopathy, although it's not very important for the exam, but you should have a little idea, at least the basic of it and what's the appropriate management of it. Just that. You don't need to know the causes or anything. So remember, there are three types of cardiomyopathy, which means that your myocardium, which usually gives the contraction of your heart, is affected. So there is dilated cardiomyopathy when your myocardium gets thinner and it loses the contractility. There is hypertrophic cardiomyopathy in which the interventricular septum, so this is the interventricular septum, it gets more thickened, okay, and that's why your heart gets lack of space to take in blood. So that's your hypertrophic cardiomyopathy. Then lastly, we have restricted cardiomyopathy when the myocardium was supposed to stress. So it should be a kind of elastic kind of thing. It will stress and relax, like it will squeeze and relax like that. But when it becomes restricted cardiomyopathy, it becomes totally rigid, so it cannot stress. Okay, so that's mainly the pathophysiology. Now let's start with the dilated cardiomyopathy, which means that your myocardium will get thinner and it will lose the contractility. If it cannot contract properly, it cannot pump blood. That means it's causing a systolic heart failure, right? So systolic heart failure is the main feature of dilated cardiomyopathy. Most commonly, there is no underlying cause, which is idiopathic, but alcohol has a very good predisposing factor to cause dilated cardiomyopathy. Other than this, there are some other causes which are not very important. You can read it at your own time. The features or symptoms will be same like a systolic heart failure patient. What is the treatment? So treatment will be just what we use to treat systolic heart failure. We use ACE inhibitor. We use furosemide, furosemide, ACE, sorry. We use ACE inhibitor, furosemide, spironolactone, beta blocker. So all those medications we can use here. Obviously, ejection fraction will be less than 35%. So any patient with a diagnosed case of dilated cardiomyopathy with the ejection fraction less than 35%, they have the indication to use AICD. So see that this is the normal heart. But in case of dilated cardiomyopathy, your myocardium gets very thin and it's like that. So see, this is called dilated cardiomyopathy, and it is unable to cause contraction of the myocardium. So there is enough blood in your heart, but it cannot contract. So if it cannot contract, heart will the blood will not pump out to your body. So ejection fraction will be low. Next one is the hypertrophic obstructive cardiomyopathy. Now this one is a genetic or hereditary condition which is mainly autosomal dominant. So most of these patients, usually they have a history in their family that someone died very early due to sudden cardiac death. So sudden cardiac death in the family is one of the clue for hypertrophic obstructive cardiomyopathy. Always think that if in the exam they say something like that, it's a HOCM, most likely. What happened in here? So your interventricular septum, see this is the interventricular septum, and see the hypertrophic one. So it becomes hypertrophied, and see that there is lack of space for the blood to be in your left ventricle, right? So as a result of the hypertrophy, left ventricular compliance will be reduced, but systolic performance is okay. So that means it's causing a diastolic dysfunction because of reduced space, right? So decreased compliance, heart cannot fill up properly, which means it's causing a diastolic dysfunction. But one of the important thing is that as your heart or left ventricle become hypertrophied, it contracts very rapidly. So ejection fraction sometimes it can be 80% or 90% in this patient. So ejection fractions are often 80-90% in this patient. And heart becomes hypercontractile, and you can get systole with a striking rapidity. Sometimes what can it cause? That if you see here, it can also reduce cardiac output sometimes, but not always. If due to any reason this hypertrophy of the interventricular septum can obstruct the flow of blood into your aorta. See, this is how it can cause it. So this is the only time it can also cause reduced blood flow in your body, but not very important to know. The important thing is to know about here is some of the feature will help you to diagnose HOCM. Obviously, this patient can have dyspnea, this patient can have heart failure feature, but as I said that sometimes it can reduce the blood flow in your aorta and also in your coronary arteries. This patient can come to you with angina features as well. Okay, so they can have angina, syncopal attack, everything. And because of this lack of blood supply from your heart to the aorta, sometimes from the aorta, from here the blood will go to your brain, right? Now, if your brain doesn't get enough blood, you can develop syncope or loss of consciousness. That's why many patients with HOCM can present to you initially as a syncopal attack. And also because of hypercontractility, you can get large jugular wave, bifid carotid pulse, S4 gallop, and a systolic murmur. Okay, so the murmur of HOCM is pretty much same as aortic stenosis murmur. So it's also ejection systolic murmur. Sudden death is sometimes can be the first manifestation also. Any patient you suspect to have HOCM, even though ECG cannot diagnose it properly, that patient should have a ECG first, because we don't know, like we can get left ventricular hypertrophy in the ECG sometimes. So we need to do a ECG first in any patient, as I say, in heart failure ECG first, because you can get underlying MI in that patient, right? Or you can get uh, ST depression, you can get T wave inversion. So anything can help you to understand underlying cause. So that's why ECG first. And to confirm, you need to do a echocardiogram. Sometimes, if you just do a like a resting echocardiogram, you might not find HOCM. What if you do a stress echocardiogram? Sometimes, if you do a stress or exertion, the hypertrophy, the effect of hypertrophic left ventricle gets more increased. And then you can confirm your diagnosis. So in the exam question, sometimes they say that ECG is normal and echo is normal. What's the next thing you want to do? You want to do a stress echocardiogram. Okay, if you suspect a patient having this HOCM, you have to go to the end. Mainly the question will come like a 15-year-old boy coming to you with a syncopal attack while playing. It's not the first time, he had this before also during exertion. Normally he is completely fine, and he has a family history of sudden cardiac death. Like a maternal uncle has died at the age of 35. So what's your diagnosis? HOCM, most likely. Also, they can give you some systolic murmur, something to help you to diagnose. What's the next investigation you are going to do? ECG. ECG you have done. What's the next you are going to do? Echocardiogram. Echo is normal. What's the next you are going to do? A stress echocardiogram. Clear? So this is how the stepwise investigation will be done in HOCM. Now the management. For your management part, as it's a diastolic heart failure, you have to use either beta blocker or calcium channel blocker. As you know, you should not use digoxin, you should not use any diuretics, you should not use vasodilators. Just similarly, because it's not a systolic heart failure, if you use diuretics, already your heart is not getting blood, you are removing also fluid from your body, so it will make things worse. So this is important for HOCM patient. Avoid digoxin, diuretics, vasodilator, and exercise also. Clear? So beta blocker and calcium channel blocker will be your main management in here. The last of your cardiomyopathy is your restrictive cardiomyopathy, in where your ventricle, left ventricle becomes rigid. If left ventricle becomes rigid, so what will happen? It cannot relax. If it cannot relax, it will be also causing a diastolic kind of heart failure. So myocardium is rigid and non-compliant, impeding ventricular filling. Okay, if there is ventricular filling is affected, it will cause also diastolic heart failure. Also, because your myocardium is getting rigid, there will be some systolic dysfunction in here also. So usually restrictive cardiomyopathy is very severe form. In here you get both ventric, both diastolic and eventually later on systolic dysfunction. There is no good medical treatment for this condition. Ultimately, the patient will die because of heart failure or arrhythmias. You can consider heart transplantation, but it's not very commonly found. Next is called acute pericarditis. What is acute pericarditis? This is a very important diagnostic dilemma. Patient will present to you with just similar like a myocardial infarction. What is the main important feature you will look for? Pericarditis means the pericardium, which is the outer layer of your heart, get inflamed. When it inflamed, patient will have sudden severe chest pain, mainly in the left side. And the characteristic of this chest pain is that it will get worse on lying down, on taking a deep breath, which is a pleuritic kind of chest pain, and it will get better when the patient lean forward or sit up. So left-sided sudden severe chest pain get worse on lying down, better on leaning forward. That's your pericarditis. The characteristic physical sign you can get a pericardial friction rub, which is a kind of a scratchy, high-pitched sound you can hear during your auscultation. What is the main underlying cause of pericarditis? Mainly, if the patient had some viral upper respiratory tract infection about a week ago. So mainly its underlying cause is viral infection. Or if viral infection is not the cause, then there can be some connective tissue disorder, there can be tuberculosis, or sometimes uremia, which is renal failure. It can also cause uremic pericarditis. In the ECG, you will get ST elevation in all leads. We will discuss in our ECG class how the acute pericarditis comes. But remember, globally, all the leads, like lead 1, 2, 3, all these lead will have ST elevation. Okay. And the treatment, because it's an inflammatory kind of condition, so you have to give anti-inflammatory drugs. So you just give NSAID, aspirin, and that doesn't help, you can use a steroid. Sometimes, if patient having recurrent pericarditis, we can use colchicine as well. Clear, guys? Any questions so far? Okay, now we're going to take a 10-minute break and then we'll start again. Are you enjoying the class, guys? You're not asking any question. It can mean two things, that you are not understanding anything I'm saying, or it can understand you are understanding everything. Okay, so let's take a 10-minute break and then we'll again discuss. There are lots of things to discuss also. We'll discuss that. Thank you. All right, guys, let's start. Any questions so far? No? Okay. So we have been discussing the pericarditis and we finished that, right? Now, pericardial effusion. Pericardial effusion, which means that, like between your pericardium, let's assume this is your heart and this is the outer border, which is the pericardium. Pericardium has two layers, inner layer and outer layer. When in between the inner and outer layer, there is accumulation of fluid, we call it pericardial effusion. Now, pericardial effusion is not very serious as long as it doesn't cause compression over the heart. If there is a lot of fluid accumulation, then what can it do? It can compress the heart and your heart will be unable to pump out enough blood and it can lead to heart failure eventually. So that's why it's important. Now, the accumulation of fluid can be frank blood, can be serous sanguineous fluid, can be um, can be just a transudative kind of fluid. So it depends on what type of fluid it is. If it's a serosanguinous fluid, then it's a classic sign for tuberculosis or any cancer. If it's a frank blood, it could be rupture of the aortic aneurysm or aortic dissection. Now, how to diagnose pericardial effusion? Only thing you can diagnose totally confirm is echocardiogram. Also, if you do a chest X-ray, you will find out the heart shadow is really, really bigger. See, this is how the pericardial effusion looks like in the X-ray. See how bigger it is. So that's your pericardial effusion. Now, pericardial effusion is not very serious unless it develops cardiac tamponade. So if pericardial effusion develops so rapidly that it compresses the heart, that time we call it cardiac tamponade. Cardiac tamponade patient will present to you with just like heart failure patients. So dyspnea, fatigue, tiredness, orthopnea, all the same symptoms. Some of the other physical sign that you can look for it, you can get a pulsus paradoxus, which means that when you take a inspiration, then it will have a like a decrease in systolic blood pressure of more than 10 millimeter with a normal inspiration. Also, the paradoxical pulse often can be noted by marked disappearance of a peripheral pulse during inspiration. So during inspiration, if the peripheral pulse disappear, that's also called pulsus paradoxus. So this pulsus paradoxus is a classic feature of cardiac tamponade. Also, this patient can have raised JVP. You can also find a decreased or muffled heart sound. Remember, anytime there is a word called muffled heart sound in the stem, you should always think about pericardial effusion or cardiac tamponade. The classic triad of cardiac tamponade is called Beck's triad, in which you will get low systolic blood pressure, distended neck vein, and decreased heart sound. So these three features, if you find out, you should think about cardiac tamponade. The diagnosis is done by a echocardiogram, and treatment you have to remove the excess fluid by pericardiocentesis. Clear? So that's your cardiac tamponade. So remember, cardiac tamponade, patient will have a raised JVP, patient will have pulsus paradoxus, patient also can develop all the features and sign of heart failure. But the most important sign for cardiac tamponade is your muffled or decreased heart sound. Why? Because the heart sound will be muffled because around your heart there is fluid accumulation. So it will be very muffled. You cannot even hear the heart sound. The next condition called constrictive pericarditis. Constrictive pericarditis, in which the pericardium gets thickened in response to some inflammation. If pericardium gets thickened, your heart will be unable to relax or distend, because your your heart is enclosed within pericardium, right? Now, if this pericardium is rigid or thickened, your heart will be unable to stress. So if your heart is unable to stress, what will happen? There will be diastolic heart failure, and also the same way, your heart will be unable to receive enough blood from the lower extremities. So in that case also you will get dyspnea, orthopnea. Now in this case, because your heart is unable to receive blood, so there will be systemic fluid accumulation that will be just like similar right heart failure features, which means you will develop raised JVP, you will develop bipedal edema, you will develop ascites, tender hepatomegaly, all the features of right heart failure, you will get it here. Okay, in here also heart sound will be a little distant. You can get pericardial knock, and sometimes this pericardial knock can be confused with S3 gallop. You don't need to remember that. You just need to remember in constrictive pericarditis, patient will come to you with dyspnea, orthopnea, and you will get features of right heart failure. With that, one thing is important, that heart sound will become distant. If you do a chest x-ray, you will get a egg shell appearance. See this, this is this whitish thing you can see all over the heart border. This is called egg shell appearance. This egg shell appearance is because your pericardium got thickened due to lots of so that's your constrictive pericarditis. Now, there is no other conditions like we finished heart failure, we finished other condition like constrictive pericarditis, pericardial effusion, pericarditis, okay, all, and also valvular heart disease. Now we'll go through a little bit about the hypertension, how we can manage hypertension, and some of the important topics related to hypertension. Now, in a normal patient who is an adult more than aged 18-year-old, hypertension we call if systolic blood pressure more than 140 and or diastolic blood pressure more than 90. So our cutoff point is 140 by 90. Okay. Grade 1 hypertension is 140 to 159, 90 to 99. There is a grade 2, grade 3 as well. We don't need to remember or memorize the grading, but we just need to remember what is normal. What are the causes of hypertension? In 95% cases, there is no cause, which is called essential or primary hypertension. That means there is no underlying cause of it. Other 5 to 10% cases, there could be some secondary causes, mainly related to kidney. So it could be renal artery stenosis, could be glomerulonephritis, reflux nephropathy. Okay, some of the endocrine cause like Cone syndrome, Cushing syndrome, pheochromocytoma, using oral contraceptive, steroids can increase your blood pressure. Coarctation of aorta is one important cause. One of the drug called NSAID or a steroid also can increase your blood pressure. Now, some of the important features or physical sign can help you to find out these secondary causes. Like if you're thinking about renal artery stenosis, you should always look for any abdominal bruit or renal bruit. So if you get a renal artery bruit, probably that's renal artery stenosis. For glomerulonephritis, we know that those patients usually present to you with hematuria, proteinuria, edema. So that's also you can look for. For polycystic kidney disease, you should always get some palpable kidney in your abdomen. So bilateral kidney masses with or without hematuria with a family history of polycystic kidney disease. For coarctation of aorta, radio radial delay, radiofemoral delay, that's your important feature. Some of the patients with sleep apnea, like obstructive sleep apnea, who are very obese, they can also develop hypertension. And for pheochromocytoma, those patients usually present with episodic headache, sweating, hypertension, and palpitation. So episodic headache, hypertension, sweating, palpitation, that's pheochromocytoma. Pheochromocytoma is a tumor of your adrenal gland, mainly your, this is a like, in this case, your the adrenal gland will produce lots of catecholamines. So there will be lots of sympathetic drive. Due to increased sympathetic drive, you will get hypertension, headache, sweating, palpitation. All of these are related to sympathomimetics action of the adrenal gland tumor. So these physical findings are really important to find out the cause of secondary hypertension. So, and again, if you get any epigastric bruit or any renal artery bruit, think about kidney artery stenosis. If you get any flank masses, think about polycystic kidney disease. If you get absent femoral pulse or radioradial delay, think about coarctation. If you get truncal obesity with a moon face, pigmented stria, think about Cushing syndrome. Okay, so we'll discuss all these things later on, but not today. There are two terms called malignant hypertension and refractory hypertension. Malignant hypertension, when you develop diastolic pressure more than 120. With that, if you have any end organ damage like kidney damage, retinal damage, then we think about malignant hypertension. For refractory hypertension, when you develop blood pressure, that means when you have hypertension, it's despite using maximum dose of at least two drugs. Now, if you think about renal artery stenosis as a cause of the hypertension, most of the time we think about two causes which can cause renal artery stenosis. One, which is mainly for elderly patients, which is atherosclerosis or formation of thrombus or fatty plaques in the kidney artery causing the stenosis. Or if it's a young girl coming to you with secondary hypertension and you have found a epigastric bruit or renal artery bruit, you should always think about fibromuscular dysplasia. If you want to confirm your diagnosis of renal artery stenosis, the diagnosis is only can be done by a Doppler ultrasound. If you do a Doppler, you will find out that how much stenosis is there in the kidney artery. Now, any patient having, like any patient, any person aged more than 18-year-old, the screening, sorry for that, the recommendation of the screening is every patient should have a BP measurement from the age of 18-year-old every 2 yearly. So from 18-year-old, every 2 yearly, we should measure blood pressure for every patient. This is a screening for general population. Now, what if you got a patient and you find out that single visit there is hypertension? Can you diagnose it? No. If you want to diagnose someone with hypertension, the initial high blood pressure reading should be confirmed in another visit within the next 3 months time. So first visit more than 140/90, in the next 3 months again you have checked it in another visit, again it was more than 140/90, then you can only diagnose it as a hypertension. So this is the general follow-up criteria or management for any hypertension depending on the grading. If the blood pressure is less than 120 by 80, you can recheck in 2 years' time. If between 120, 130 and 80 to 89, recheck in 1 year. Now, when becomes grade 1, 140 to 159, 90 to 99, then you have to confirm it within the next 2 months. Also advise lifestyle modification in this 2 months' time. When it becomes more than 159, that means 160 to 179, and diastolic more than 100, then you need to refer within 1 month's time, or you need to recheck within 1 month, advise lifestyle. Whenever it becomes more than 180 or more than 110, you should start blood pressure lowering medication at this time. You don't need to recheck it. You can do recheck in 1 week time, but most of the time you should start medication. Okay, it's not very important, but just you need to memorize it, just if sometimes comes in the exam, so that you can understand or you can get it correct. So it's not a recommendation to start any patient with antihypertensive whenever you just find out hypertension. So you have to confirm it within the next 3 to 6 month time before you start therapy. Always start with the lifestyle modification unless the initial blood pressure is more than 180 or 110. Again, whatever is the blood pressure is, if any patient with a hypertension has target organ damage. What is target organ damage? If you have hypertensive retinopathy, so any vision problem due to hypertension, if you have a stroke due to hypertension, if you have coronary artery disease related to hypertension, if you have kidney damage due to hypertension, these are all target organ damage. In those patients, you have to start immediate drug therapy. Okay. So the basic thing is, if you get a patient who has like blood pressure of systolic blood pressure 150, diastolic is like 100, so 150 by 100, what you would do, you would advise the patient to follow lifestyle modification for the next 3 months, or at least for 1 month, and then recheck the blood pressure. Again, it's high, so it's a diagnosed hypertension. Then you can ask the patient to do some lifestyle modification for the next 3 to 6 months. If it's high, even though he is doing lifestyle modification, then you can start antihypertensive. There is a term called ambulatory 24-hour blood pressure monitoring, which is not similar as Holter monitoring. Don't confuse Holter monitoring with ambulatory BP monitoring. There are some patients in which if you check blood pressure in the clinical setting, it will be really high. But when the patient will be at home, relaxed, their blood pressure will be normal. This term is called white coat hypertension. So for those white coat hypertension, or some of the patient has very, like in one setting, your blood pressure was 160 by 100. Just within 1 week, you recheck the blood pressure, it came as 100 by 80. Then again, you checked like in 1 or 2 days later, it's 140 by 120. So those patients who has like marked discrepancy between frequent blood pressure measurement, they usually should have a ambulatory blood pressure monitoring to find out in 24-hour time what's the blood pressure looks like in this patient. So for those patients, we use ambulatory BP monitoring. So those patients who has fluctuating level, those patients who has white coat hypertension, unusual variability of blood pressure, marked discrepancy between office and home BP, who are resistant to drug treatment, suspected sleep apnea, for those patients, you can use ambulatory blood pressure monitoring. Okay, clear? So this is particularly important because in the exam question, they give you like a patient presents to you, 35-year-old man whose blood pressure today is 170 by 100. 2 days ago, this patient also came to your GP clinic. You found out his blood pressure was 110 by 70. What's the next investigation you are going to do? So there is a marked discrepancy between today's blood pressure and just previous blood pressure. For marked discrepancy, we need to do a ambulatory blood pressure monitoring. Clear? So the non-pharmacological management is the initial management for hypertensive patient. So if the average diastolic blood pressure is 90 to 100, there is no evidence of end organ damage, non-pharmacological therapy is indicated for 3-month period without use of anti-hypertensive drug. Also, try to remove anything which can increase blood pressure like NSAID, steroid, OCP, hormone replacement therapy. What are the other lifestyle modification we can do? The most important lifestyle modification is to reduce the body weight. So if you can reduce 1 kilo of body weight, the blood pressure can drop by 2.5 millimeter of systolic blood pressure. So that's the vital part. Also, reduce alcohol. We have reduced sodium intake or salt intake, reduce smoking. But the most important is to reduce the weight. Remember, sometimes exam question, you can get confused with doing exercise. Exercise is important, obviously, but the most important is to reduce the body weight. Now, you want to start antihypertensive for this patient. How you can start it? Always remember, if it's an elderly patient, more than 55-year-old, you can start with either ACE inhibitor or ARB, or you can use calcium channel blocker. But if it is more than 65-year-old, for this much elderly patient, better to use a low-dose thiazide diuretics. Okay, so young patients usually better to use ACE inhibitor. Very elderly, like more than 65, start with the thiazide diuretics. Now, someone of you asked me that beta blocker we use as a first line therapy. If you see that ACE inhibitor, calcium channel blocker, and thiazide, this is your first line. Your beta blocker is not the first line. Only we use beta blocker is very much like at the last time when nothing is actually working at that time. If so, you will start with the single medication first. If the target is not reached within 3 months, then you can use the combination of any of these three. The best combination is using ACE inhibitor with a calcium channel blocker, or ACE inhibitor with a thiazides, or ACE inhibitor with a beta blocker. And the lastly, then you can use the three of it together. Now, why I'm discussing that, some of the combination is not important or should not be used. Like, if you draw a circle like that, in here you have ACE inhibitor or ARB, you have diuretics, you have beta blocker, you have calcium channel blocker, A, D, B, C. You can use any of this combination which is congruent to each other like this, but you should not use anything which is like cross like this. So these two combination is not effective. So A and B, so ACE inhibitor and beta blocker is not very effective, and using calcium channel blocker and diuretics is not very effective. So that's why relatively ineffective combination is diuretics, that means C and D and A and B. So don't use that combination. Best is starting with a ACE inhibitor and a calcium channel blocker, or ACE inhibitor with a diuretics. And never use beta blocker and rate limiting calcium channel blocker, because Beta blocker also reduce the rate. Verapamil also reduce the rate. You can precipitate heart block, heart failure for this patient. Okay. And also do not use spironolactone with a ACE inhibitor or ARB, because ACE inhibitor ARB increase potassium. Potassium sparing diuretics like spironolactone also increase potassium, so you can cause hyperkalemia. Also do not use ACE inhibitor and ARB both in a patient, because both of them the similar effect. Usually we start with ACE inhibitor. Only time we use ARB when a patient cannot tolerate ACE inhibitor due to dry cough, because ACE inhibitor can cause dry cough, which is very troublesome. Then you can switch to ARB. Okay. Now, the most important topic from your hypertension is this chart, because you need to find out what is the best antihypertensive for your patient. It's not only depends on the age of the patient, it depends on the other medical condition your patient has got. So you have to always look for those things before you start any antihypertensive. Like for a patient who is having asthma COPD, you cannot use anything which causes vasoconstriction. Like you should not use beta blocker in a patient who is having asthma COPD, contraindicated. So for them, you can use any of it, ACE inhibitor, calcium channel diuretic, anything you can use, but not a beta blocker. For a patient who is having constipation, you should not use calcium channel blocker. It's very notorious to cause constipation. Also do not use diuretics. Use ACE inhibitor. For a patient who is having bradycardia or heart block, if you use any rate limiting drugs, it will be more worse. So do not use beta blocker. Do not use calcium channel blocker. Better to use diuretics or ACE inhibitor for those patients. Again, for heart failure, better use ACE inhibitor or diuretics. If it is decompensated or severe heart failure, don't use calcium channel blocker or beta blocker at that time. For systolic heart failure, okay? Then for diabetes, remember, we cannot use thiazide diuretics because it can cause glucose intolerance or insulin intolerance. So for diuretics, for diabetes, diuretics is contraindicated. Very good drug is ACE inhibitor for diabetes patient. This is one of the important question you should remember. Again, dyslipidemia, usually diuretics can cause dyslipidemia, so we prefer to use ACE inhibitor for those patients who is having dyslipidemia. For patient who is having hyperuricemia or gout, again, do not use diuretics. Use ACE inhibitor. For ischemic heart disease, anything you can use. Now, another important is those patients who has peripheral vascular disease. Like you have got a patient who has PVD. PVD means their lower extremities arterial supply is not sufficient because of formation of some clot or atherosclerotic plaques. Now, if you use something which will cause vasoconstriction, that will constrict these arteries more, and it will cause this PVD lot more worse than before. So for PVD patient, you should not never ever use beta blocker. You can use drugs which dilates your vessels. One of them is calcium channel blocker because it can dilate your peripheral blood vessels. So for PVD patient, best is calcium channel blocker. For pregnancy, you cannot use diuretics, you cannot use ACE inhibitor, only you can use calcium channel blocker, beta blocker, or mainly methyl dopa we use. For Raynaud phenomenon, again, calcium channel blocker is the best one. Kidney artery stenosis. This is a particular area of interest for AMC. For any patient having renal artery stenosis, now if it's a unilateral, that means just once one renal artery is stenosed, you should use ACE inhibitor for this patient. If both or bilateral renal artery stenosis, then best medication is to use calcium channel blocker. Okay, so remember these two things is very important. It comes in the exam very frequently. So for those patient who is having unilateral renal artery stenosis, ACE inhibitor. Those patient who is having bilateral renal artery stenosis, best is CCB. Clear, guys? Any question? So if I ask you that what is the best medication if you want to use, if a patient comes to you, he's a 65-year-old man and diagnosed hypertension with a history of diabetes and dyslipidemia. Okay, so what medication you will start this patient with? 65-year, but having dyslipidemia, having diabetes. Are you going to start diuretics, thiazide diuretics, or you will start with the ACE inhibitor or calcium channel blocker? Yep. Best to start with the ACE inhibitor or calcium channel blocker. Not better to use thiazides for this patient. Good. Any questions so far from the hypertension? All good. Now, this is mainly our today's session. The palpitation is usually we will discuss during our ECG because when we discuss the ECG class, palpitation should get covered at the same time. Usually we do that at that time. So let's not make your brain more clouded by going into the palpitation without doing an ECG. So that's mainly your cardiology. I guess that cardiology was helpful for all of you. And the next, I just let me have a look. So you have a class on 9th of November on cardiology question discussion. So we will discuss our cardiology question based on this theory session. And during this time, we will understand the questions a lot more better way. And your 2 weeks free session is going to be finished on 10th of November. And after that, we will start our normal batch session, like the paid session for our 5 months MCQ course. So if you guys still want to join, please make sure you join within this 10th of November because after that admission will be closed. So make sure you at least contact with our team with email or with messenger, whatever you want. Already our 5 months batch is more than filling up. So if we get enough students for this batch, we will stop the admission very soon. Okay. Now, if still any of you wants to join, make sure you just give us an email so that we can prepare your spot for the 5 month session. Okay. So there is a term, very good question, doctor. So isolated hypertension, right? So if you look at here, this is called isolated hypertension. If Now, if you see that sometimes patient can get only systolic blood pressure is more than 140, but diastolic is less than 90. Okay, so only isolated systolic hypertension. That is called isolated. That means diastolic is normal, but just the systolic is elevated. These patients also will need treatment. Any question? Those who are in the Facebook, do you want to ask any question? So this is our today's session. Thank you so much for joining our today's class. Okay. If you feel that there is any problem with understanding, or if you don't understand any of our class, okay. Sorry, I think my voice is echoing. Just give me a second. Okay, so it's coming from the Facebook, I think. So if you feel anything difficult, or if any of the cardiology topics has been missed, feel free to ask it in our question solvation class on 9th of November. Then we will cover that up. So thank you so much for joining these sessions. Have a good night. Bye.